a 78-year-old man who presents to his GP with low back pain. And I might say, as we go through this case, it's designed to be as interactive as possible, so please speak up and butt in at any point. He has a known history of metastatic prostate cancer diagnosed 2 years ago with multiple asymptomatic bony metastases, and to date he's been managed with hormone therapy, goserelin alone, and his prostate remains in situ and he has no lower urinary tract symptoms. So overall, he's a well man. He's got a good performance status. He's got hyperlipidemia and atrial fibrillation. He takes atorvastatin and warfarin, no known allergies, non-smoker, and doesn't drink any alcohol. So the history that he gives is a 6-week period of constant burning pain in the lower lumbar region, worse at night, 7 out of 10 in severity, and no relief with regular paracetamol or non-steroidal anti-inflammatories. He has no lower limb weakness, numbness, urinary or bowel symptoms. So I guess we'll go through the questions to work this gentleman up. So to begin with, what physical examination would you perform?
Start with his basic obs first of all.
Yep.
And then go on to physical examination. Start at the top and move down as we normally would. So eventually get to the back and spine and neuro and all that. Yeah,
absolutely. So as you say, neurological examination, upper limb, lower limb. And I guess that leads to the next point. What might the differential diagnosis be in this case?
Might be plain osteoarthritis.
Yep. Was it osteoarthritis? A musculoskeletal cause? Yeah, absolutely. One of the most common causes of back pain. So that's a first cab off the rank. Given his history of
osteoporotic crush fracture.
Yes.
And maybe bone rest.
Absolutely, yeah. And I think that covers sort of the main differentials. And we've alluded to it already. What important oncological emergency would we like to exclude in this gentleman?
Spinal cord compression.
Yeah, absolutely. Just for those at the back, a spinal cord compression. So what investigations might you want to order at this point? Any blood tests? No?
Recheck his PSA.
Yeah. Thank you.
Yep.
So recheck PSA.
In terms of imaging, bone scan.
Yep, absolutely, yeah. Thank you. And we've mentioned that he started on Panadol or paracetamol and NSAIDs. Would we consider prescribing anything else for the pain, something stronger?
Opioids.
Yes, the WHO pain ladder, I'm sure we're all au fait with that. So upper and lower limb neuro exam is normal. He has a bone scan, and this shows a new metastases in a number of sites, but in particular L2, which is the site of his pain and why he's come to see you. So what is the diagnosis? I think it's fairly straightforward at this point that this gentleman has progression of his metastatic prostate cancer with a new painful bone metastases at L2. And he has a trial of oxycodone and paracetamol for 1 week, but the pain persists, it doesn't respond. So what options might he have now? Excellent answer. So obviously, this is a radiotherapy case, so one of his options definitely would be a course of palliative radiotherapy. What are the practicalities of radiation therapy for bone metastases? Has anyone had a patient in the room that's had a course of palliative radiotherapy? Yes?
Prostate cancer.
Oh, there you go. So, yeah. And you may have witnessed the practicalities for a patient having this sort of treatment. It's actually, as Sandra alluded to before, it's actually a very well tolerated treatment and usually involves very minimal inconvenience to the patient. They typically have a CT planning session, which is just a simple CT scan. It wouldn't take more than 30 minutes, 45 minutes at most, and wouldn't require contrast. And then treatment itself, Peter and I were discussing this, most patients with bone pain requiring palliative radiotherapy only require one fraction of radiotherapy, and that is delivered within 5 to 10 minutes. Occasionally we consider a slightly longer course, up to 5 treatments. It's rarely longer than that, but it can be, and there'll be specific reasons for that. And what can the patient expect in terms of pain relief, time to pain relief and durability of pain relief? Overall, it's excellent. 70 to 80% of patients will have a significant and durable control of their pain. So it's excellent, really. And the other benefit of that is that these patients then can roll back on those opioid medications, which we all know have problems with constipation and drowsiness, and I think a vast majority of patients would much prefer not to be on opioids. So overall it's excellent. So what are the expected side effects and how are they managed? Look, overall very well tolerated treatment with minimal side effects. It does depend on the area that we are treating. In this case, the bowel is in front of that region of the lumbar spine. It may be a small degree of nausea or alteration of bowel motions, but usually not. Other than that, it's very well tolerated.
There's one other point in the general practitioner setting about this case, which is a very good case, and that relates to that window of opportunity between when a patient presents with radicular pain and when it progresses to spinal cord compression. So the symptoms that you described, there is a window of opportunity for early diagnosis and early referral, which will translate into better outcomes for the patient. So an early MRI scan, which we didn't really cover, is really helpful in terms of making the diagnosis early and expediting a quick referral to radiation oncologists, which will translate into better outcomes for our patients. If we wait till the patient's incontinent or their legs aren't working, then the outcome's going to be worse. So having that in the back of your mind with a patient with metastatic prostate cancer, with back pain, particularly if there's a radicular quality of it or a parasitic band around the patient, are very useful clues in terms of making the diagnosis.
Well, I guess one of the whole points of this evening is to know that your friendly local radiation oncologist, we like to know about potential malignant spinal cord compressions early in the piece because it results in better patient outcomes. So I guess the point of that is that if in doubt, contact a radiation oncologist, to bounce it off. We're always available to help.